Hello everyone, and welcome to a short screencast on wound classification and the stages of wound healing. So the reason that we need to know this is because we want to increase a positive surgical outcome for patients by decreasing perioperative complications from misidentified risk factors for infection and sepsis. And so if we look at the percentages of the different classes of wound classification, we will see that Class 1, which is also known as a clean type of classification, will have a 2% chance of infection. Class 2, which is also known as a clean contaminated classification, will have 5 to 15% chance of infection. Class 3, known as contaminated, would be greater than 15%, and Class 4, being a dirty type of classification, would mean that there's a greater than 30% chance of infection. So let's go through and talk about what terms we can use in order to take a wound and classify it into these 4 categories. So to do our wound classification, we want to use it to predict the risk of our post-operative infection based on the assessment of the bacterial load at the time of surgery, meaning as the surgery is going on, you are looking for things like if the aseptic technique was interfered with at all. And we'll look at some other factors as well. And it also is going to assist the surgeon in determining what their approach would be to post-operative care. Maybe they'll decide to either dress or undress the wound and so forth. So here is our Class 1 or clean classification of a surgical wound. It means that it is uninfected, there's no inflammation, and our respiratory, should have been a comma here after respiratory, alimentary, meaning the gastrointestinal tract, genital or urinary tract was not entered. The clean wound is primarily closed, and if it was needed, it was drained with closed drainage. There was no break in aseptic technique, and examples of this would be a C-section with non-ruptured membranes, a mastectomy or breast removal, a neck dissection, eye surgery, hernia repair, or a splenectomy where we would take out the spleen. And for Class 2, this is also known as a clean contaminated classification, meaning there was no major break in the aseptic technique and no acute inflammation, no spillage, and our respiratory, gastrointestinal, genital, or urinary tracts were entered, but they were under a controlled condition and without an unusual type of contamination going on. Typically, the operations that this would be classified as Class 2 would involve the biliary tract, appendix, vagina, or the oropharynx. And examples of this would be a cholecystectomy at the point where there was chronic inflammation, so we're removing the gallbladder here, and gastrointestinal procedures, gynecological and urological procedures. And then we get to our Class 3 or contaminated surgical wound classifications. So at this point, we would see that there's acute or non-purulent inflammation encountered. And what that means, you might not have heard that word purulent before, but if something is purulent, that means that there's been some type of acute form of exudative inflammation, meaning the enzymes are going to produce white blood cells to liquefy the affected tissues and create pus. So we're not seeing pus at this point. The wound is also open and fresh. It could be an accidental wound. Operations with major breaks in sterile technique would be Class 3. Visible spillage from the intestinal tract would take place, or we would see necrotic tissue, meaning tissue death, without evidence of purulent drainage. And examples of this would be an appendectomy, where there was no rupture and no pus, bowel resection for infarcted and or necrotic bowels, cholecystectomy with an acute inflammation or bile spillage, and compromised integrity of the sterile field. And our last classification would be class 4 or dirty infected classification. So here we would start to see that presence of frank pus or abscess. So pus is always going to be thick and white and like a whitish yellowish fluid, which represents an accumulation of the white blood cells, liquefied tissue, and some cellular debris. And an abscess is just a swollen area in the body tissue that contains an accumulation of pus. We could also have perforated viscera here. Viscera is referring to any of our organs. Fecal contamination, traumatic wounds with retained devitalized tissue, wet gangrene. And some of you may be familiar with what gangrene is, which is a death of body tissue because we have reduced blood flow or there's been a serious type of bacterial infection. But what makes it wet is when we have the bacterial infection of the affected tissues rather than the lack of blood flow. So examples would be amputation in the presence of an infection, laparotomy for intra-abdominal abscess, incision and drainage for infection or abscess, ruptured appendicitis, ruptured bowel with or without fecal contamination, and lastly, ruptured gastric ulcers. So that brings us to tissue damage and inflammation. So we basically want to talk about how tissue damage is going to take place and what our immune response to that would be. And so here we have listed under manifestations the 5 cardinal signs for inflammation. You may have learned 4 cardinal signs of inflammation, but they have decided to add a 5th one. So that would be redness, heat, swelling, and pain, and disturbed function, or some people say lack of function here, or incapability of functionality. And so one of the first things that's going to happen is we get a release of chemical mediators when we get some type of tissue damage that takes place. And that would include a release of histamine, kinins, prostaglandins, or leukotrienes. And so what their job is to stimulate the pain receptors and increase the blood vessel permeability as well as movement of those white blood cells to the affected area. Now this is one of my favorite pictures to talk about inflammation. I just threw it in here, so I'm going to update your slides and make sure that this one is in there as well. But you could see that right here a wound has taken place, and the black little guys here are representing the bacteria. And so the platelets are going to come in order to start to clot up the blood vessels that were broken. And then our mast cells are going to start to release those chemical mediators. And that will cause these blood vessels nearby to increase their permeability and also vasodilate. So increasing permeability means that the simple squamous epithelium here, or endothelium as it's known as, will start to pull away from each other so that it can allow the white blood cells moving through the blood to squeeze through. This process is called diapedesis, just so you know. And we'll move into the tissue area, and a white blood cell like a neutrophil or also a macrophage will go through and phagocytize the bacteria, and that will, as it's killing these bacteria, that may cause some debris to lay behind and add to the pus that is being created. We will also see that there will be some cytokines that will be released from macrophages, which will initiate tissue repair, go back and signal to our blood vessels, and also some of our other cells to continue with the inflammatory response of our body. So here's another diagram. This one is straight from your, I believe it's from your book, or I may have taken this from a anatomy and physiology book. So if you get a splinter, for example, you will start to see the bacteria in that area basically our goal is to kill this bacteria. So you'll start to see that process that we discussed earlier where the chemical mediators will be released and the white blood cells will leave the blood and move into the tissue area in order to go through phagocytosis and eat the bacteria in order to get rid of them. So that brings us to some more discussions on tissue repair. Our job is to have a substitution of dead or damaged cells by viable or functional cells. And so we have three major types of cells within our body. We can classify them as being labile, which means that they can go through mitosis throughout your entire life. So this would be cells within your skin, mucous membranes, hemopoietic tissue, or lymphatic tissue. We have some cells that are stable, meaning they don't go through mitosis after you finish growing, so in your adult life. But they can go through mitosis and divide after you've been injured. So these would be cells in the liver, pancreas, or endocrine cells. And our last classification is permanent. So that means if they are killed, they are replaced by a different type of cell, and they have limited regenerative ability. So this includes nervous cells in your nervous system, skeletal, and cardiac muscle. And there's a lot of debate within the nervous system because we used to think that once you lost your neurons that you wouldn't be able to get them back, but we are seeing more and more research finding neurons within your central nervous system in which they can regenerate. So that's really promising. So when we discuss skin repair, we have two types of unions. We have the primary union, in which the edges of the wound are close together. So what ends up happening is we have that wound fill with blood, and we get a clot that is going to form, and that includes some fibrin threads that'll contract and help to pull the edges of the skin together. That develops into a scab, and our inflammatory response would, of course, take place, which we discussed previously, and the pus forms as our white blood cells are going to die. Below this area, there's my mouse. Below this area, you will have some granulation tissue. This eventually will move on up and replace the clot here. And we have some delicate connective tissue that's going to be composed of fibroblasts, collagen fibers, and capillaries. So you can see some of the collagen represented over here. You will have a scar here formed from the granulation tissue. The tissue will be a little red at first, but then will turn to white as the capillaries are forced out of this area. The other type is going to be our secondary union, and this means that the edges of the wound are not close together, and so they don't really close well. And this means that we have a greater chance of infection. So the clot that gets created does not close the gap. You can see that the edges are extremely far apart here, and our inflammatory response will be much greater, and that's represented by all of these white blood cells gathered in this area here. And our wound contraction will occur, leading to greater scarring. So you can see a lot more collagen kind of gathered here together underneath where the wound was had taken place. And this is just a summary of tissue repair once again, just in case you preferred this illustration more than the previous ones. So that is it for this screencast, and there is a quiz that you have to take on Blackboard. It will be under week 4, the week 4 tab on Blackboard. And if you do have any questions at all, please feel free to contact me at any time.